since we got a pituitary gland, sometimes you can have hypersecretion of the pituitary gland, but sometimes your pituitary can fail you. Okay? There are certain times there could be problems in the pituitary gland that your pituitary completely just shuts down. Okay? So if it shuts down, what's going to happen? What's going to be your presenting features in those patients?
Secondary amenorrhea.
So basically the hormones that are being secreted from your anterior and posterior pituitary gland is going to be gone. So the symptoms have to be pertaining to it. Right? So when you think about it, from your anterior pituitary gland, what do we have secretion of?
TSH.
ACTH, okay. TSH, good. What else? Huh?
FSH.
Right. So you got FSH, LH, what else? Prolactin. What else? Growth hormone, right? That's basically it from your anterior pituitary, right? Posterior pituitary typically secretes what? ADH and oxytocin. Okay. Now, when you look at all of these hormones, which hormones do you feel like are going to be causing the most amount of problems if you don't have it? TSH, absolutely.
ACTH.
And ACTH are going to be the ones that are actually going to give most of the problem. Do you care if you don't have prolactin, sir? You don't, right? You don't care, right? Do you care if you don't have FSH and LH, Duke? You don't, right? I mean, you might have problems, right? But can you live without TSH and ACTH?
No.
Probably not, right? Also growth hormone, right? If you don't have it, the big question is what is going to be more life-threatening and what's going to be more in relation to causing problem with sexual stuff, right? So if you're thinking of panhypopituitarism, if somebody's got something that's going to cause your pituitary gland to fail. So what are some of the reasons why the patient's pituitary gland can fail? Okay, so you can have something called pituitary apoplexy. Okay, what is that?
Infarct of the pituitary.
So imagine you had a pituitary adenoma, right? Imagine you had a pituitary adenoma that's growing, right? When you have an adenoma that's growing, can you run out of blood supply to it? You can. So if you run out of blood supply to it, can you infarct within it? Yes, you can actually infarct within it. But sometimes you can also bleed within it. So pituitary apoplexy, it could be an infarct or bleeding within an existent tumor in the pituitary gland. That is known as pituitary apoplexy, right? Okay, so if somebody had a prolactinoma or had any pituitary adenoma like a growth hormone secreting, the problem can happen within that, right? That's pituitary apoplexy. Immediately it's bleeding, you will have compressive symptoms because that tumor is now going to enlarge because of edema and whatnot. So whenever you have an elevated, when your pituitary gland increases in size, one of the most important symptoms you're going to come with, visual. Bitemporal hemianopsia is what you're going to look for. Apart from that, you're going to raise the intracranial pressure. So you will have headaches, you'll feel nauseous, you can have vomiting, right? All of those things can be present, but most of the time what you want to look for is bitemporal hemianopsia, right? Okay, what are some other causes?
Sheehan syndrome.
Sheehan syndrome. What is Sheehan syndrome?
It's usually in pregnant women. They have like, if they have extreme blood loss, it leads to I guess like infarct of the pituitary?
Yeah, but why does that happen? So the big thing is when somebody gets pregnant, does the pituitary gland grow in size? Yes, it does, right? It grows in size. So moment the patient delivers a baby, what happens if she has postpartum hemorrhage, acute blood loss, you're going to decrease blood flow to the pituitary gland and therefore you're going to end up with an infarct. Now this is not a bleed, but an infarct. Whereas pituitary apoplexy could be both an infarct or a bleed. Okay, good. What else?
General.
Huh?
General.
Congenital lack of empty sella. Sure, you can have empty sella. Okay. What else?
Kalman. We're going there.
What is Kalman syndrome?
It's the like.
It's not really a reason for. It is not really a reason for panhypopituitarism. It's only for the sex hormones, right? It's GnRH. It's because during development, what is supposed to secrete GnRH just does not get high up to the hypothalamus. So it's a hypothalamic lack of GnRH, which is called Kalman syndrome. And I think you'll also have something called merciful anosmia. They will not be able to smell things.
They have
Okay.
problems.
But it does not fall into our panhypopituitarism. So we'll wipe this one guy off, right? What else can cause it? Something else that can happen after you deliver baby. You can get some lymphocytes that go and start attacking the pituitary gland. The poor lady goes through pregnancy and then suffers all these problems. It's not nice. So what is it called? Lymphocytic hypophysitis. It's an autoimmune condition where you got lymphocytes going and destroying your pituitary gland. Typically happens postpartum in women. Okay. What else can cause panhypopit?
Something like
Radiation.
Trauma. Yes, cranial irradiation can do it, right? Irradiation. Okay. Trauma can do it. Okay, so but these are your main important causes to develop panhypopituitarism, right? So moment you suspect somebody's got a panhypopituitarism, you can imagine you don't have TSH, so you'll have hypothyroid features. You don't have growth hormone, so you might lack some growth. Now, not all of these patients should come with an acute. Sometimes yes, it's very acute. You think it's panhypopit, but everything's just shutting down. But sometimes it can happen very gradually. You can have different symptoms over a prolonged period of time, right? So when you're suspecting panhypopit, how do we test for it?
Stimulation test?
Can you order the hormones that you're missing?
Yeah.
Yeah.
You could, right? Before starting to stimulate things?
Yeah.
Okay. Alright, so best initial test, right? So what are you going to get? You can get TSH. Look for thyroid. What else can you get?
ACTH?
Yes, you can check for. You will check for ACTH or something else. ACTH is supposed to stimulate cortisol. So you won't start with ACTH. Instead, you'll check for cortisol. So you can check for 8 a.m. cortisol. Good. And what is the number you're looking for in 8 a.m. cortisol normally? I thought I just finished adrenal.
So it can't be 3, it has to be
Less than
3.
well,
Less than 3 means you do not have.
3 ones.
If it's less than 3, you have adrenal insufficiency. If it is greater than 18,
You do not have.
no adrenal insufficiency. If it is between 3 to 18, where are you at?
Limbo.
Limbo land. Very good. You have understood my language very well. Limbo land. When you're in limbo land, what do?
You stimulate.
You give ACTH stimulation test. You give ACTH stimulation test.
3 and 18 now.
Only 18 is important now. If it's greater than 18, no adrenal insufficiency. Less than 18, you have adrenal insufficiency. Okay? That's how it goes. You will get TSH, you get 8 a.m. cortisol. Okay? What else? FSH, LH. Great. What else? Can you get IGF-1 for growth hormone? Yes. IGF-1. You don't care about getting prolactin, oxytocin, and all those things. What you really care about pretty much is mostly going to be these 4. You get these 4 and you look for panhypopituitarism. Okay? If it is present, then next step is going to be imaging. Okay? And you look at the pituitary gland. Okay? Next is going to be imaging to see why the patient's got panhypopit, right? Got to get an MRI to figure it out. ADH, okay? We're going to be talking about ADH, which is called your antidiuretic hormone. What is the job of ADH? So if this is your nephron, and this is your collecting duct, right? Normally, ADH, what it does, it puts some aquaporins, okay, in your collecting duct and reabsorbs water into your circulation, right? So imagine if somebody does not have ADH, okay, for some reason. If you do not have ADH, if no ADH, what would expect to happen? If you don't have ADH, are you going to reabsorb a lot of water? No. So you're going to constantly keep peeing out water. So what would you get? You would get polyuria, right? You get polydipsia, Okay, and what would happen if you pee out all the water and not keep anything in?
Dehydration.
Dehydration, what would that do to your sodium? It will go up. So you'll get hypernatremia. Okay, you'll get hypernatremia is what you're going to get. So your sodium goes up. Now, most people, will they develop hypernatremia? Most people who you see with diabetes insipidus, because even if you're peeing out a lot, right, you have polyuria, as long as you have polydipsia telling you to drink more water, what are you going to do? You're going to drink more water. So you're going to keep peeing, but you're going to keep up with that volume loss. Unless for some reason you're peeing way more at night and you're sleeping through this whole thing, then maybe you can develop some hypernatremia, but most of the time you might not see hypernatremia as your key feature. So don't look for it. Look for your polyuria and polydipsia, because if you've got polydipsia, you're a young person, you're going to drink water. You're going to keep up with your losses. So polyuria, polydipsia equates to immediately thinking about what condition?
Diabetes?
Diabetes mellitus. You should always think about diabetes mellitus if somebody comes with polyuria and polydipsia. Right? When's the last time you saw diabetes insipidus? Not. But when's the last time you saw diabetes mellitus? Every single day. Right? So polyuria, polydipsia does not equate to diabetes insipidus. As much as we love zebras, look for the common stuff first. So always think about diabetes mellitus first. Why does the diabetes mellitus cause polyuria, polydipsia? Diabetes insipidus with this. If urine osmolality is low, serum osmolality high, tells you it's diabetes insipidus. Yes. In psychogenic polydipsia, urine osmolality should be low, but serum should also be low because your sodium is probably going to drop, right? Okay, now what are you going to do next?
Water deprivation.
Yes, so next step is going to be your water deprivation test. Present, okay. How do you treat nephrogenic? Thiazide.
Low sodium?
So you're saying that somebody, a patient, is actually coming with polyuria, right? Peeing a lot of fluid out. And your solution to the problem is to give them a diuretic to make them pee some more?
No, they cause that. Thiazides cause nephrogenic.
It's actually not. She's actually right. I'm just trying to put y'all into my favorite trap.
Oh my God.
She's actually right. It is thiazide diuretic, but why would you give a diuretic to solve a problem when the patient has got polyuria? What did I tell you about fellowship in nephrology?
It's not needed.
Why? Because 90% of the work is done by the proximal convoluted tubule. How much water is reabsorbed by the proximal convoluted tubule?
90.
80% of water is reabsorbed in the proximal convoluted tubule. Then you got loop of Henle, ascending limb, thick ascending limb, all of that combined do about 20%. Okay? So when she gives the thiazide diuretic and block off distal, how much of water reabsorption are we blocking?
20.
Maybe like 1% or 2%? Such a small amount. So what does that do though? Whenever you block this, you hyperregulate and you enhance your proximal to go into overdrive and reabsorb water. So by using a late diuretic, you stimulate your proximal tubule to reabsorb all the water, which is what it does, and therefore you will solve the problem. So the answer for nephrogenic diabetes insipidus in fact is a thiazide diuretic.